In this scenario, 4 clients await assessment. The nurse should prioritize the 63-year-old with fever, hypotension, and tachycardia, indicating potential septic shock. Immediate assessment and resuscitation are critical to prevent deterioration. When prescribing metoprolol post-NSTEMI, the nurse should question the order if the patient has bradycardia or a history of AV block. These conditions are contraindications for beta blockers, requiring careful evaluation before administration. A client with type 2 diabetes presents with confusion and high glucose levels. The most likely diagnosis is hyperosmolar hyperglycemic state, HHS, precipitated by infection. This condition requires prompt medical intervention to manage glucose levels. For a preeclamptic patient on magnesium sulfate with respiratory depression, the first step is to stop the magnesium infusion. Follow with calcium gluconate administration, prepare for intubation, notify the provider, and monitor ECG and magnesium levels. For a patient with C. difficile, essential measures include soap and water, hand hygiene, contact precautions, and dedicated equipment. Alcohol-based sanitizers are insufficient and airborne isolation is not required. When a ventilator high-pressure alarm sounds, assess breath sounds and apply a rapid bronchodilator. This approach addresses potential bronchospasm, which may be causing the alarm and patient agitation. For a 2-year-old with moderate dehydration from gastroenteritis, the best initial therapy is oral rehydration solution. This method is effective for stable children, while IV fluids are reserved for severe dehydration cases. Understanding lithium therapy involves maintaining consistent salt intake, reporting excessive thirst, and avoiding dehydration. NSAIDs can increase lithium levels, and dose adjustments should never be made without medical advice. In febrile neutropenia, immediate administration of broad-spectrum IV antibiotics is crucial. This oncologic emergency requires action within 60 minutes to prevent severe complications. For heart failure management, prioritize positioning, oxygen application, diuretics, and monitoring intake and output. Avoid potassium supplements in hyperkalemia, and ensure daily weight checks for fluid status. Safe use of restraints involves removing them every 2 hours to assess circulation. Tying restraints to bed frames with quick-release knots and maintaining patient dignity are essential practices. For a COPD client with low SpO2, apply low-flow oxygen via nasal cannula and titrate to maintain levels between 88–92%. This approach balances oxygenation needs while minimizing CO2 retention risk. To calculate heparin infusion, multiply the dose by weight and divide by concentration. For a 70-kg patient, the correct rate is 12.6 ml/hr, ensuring accurate anticoagulation management. In fetal monitoring with late decelerations, reposition the patient to the left lateral position and apply oxygen. This action addresses uteroplacental insufficiency and supports fetal oxygenation. Pre-ECT teaching includes NPO after midnight, potential short-term memory loss, and removal of dentures. Patients should not drive post-procedure, and severe cognitive decline is not expected. For a child with drooling, tripod posture, and stridor, prepare for controlled airway management. Avoid throat inspection to prevent obstruction, and secure the airway before administering antibiotics. In CKD with hyperkalemia, IV insulin with dextrose is the priority. This treatment rapidly shifts potassium into cells, stabilizing cardiac rhythm more effectively than other options. For latent TB infection, ensure the student completes preventive treatment and screen close contacts. The student is not contagious without active disease, and no isolation is needed. UAPs can perform routine tasks like obtaining morning weights for stable clients. Teaching, assessment, and titration require licensed staff, ensuring patient safety and care quality. In DKA management, initiate with fluids, cardiac monitoring, and potassium checks. Insulin administration should follow potassium management, and bicarbonate is reserved for severe acidosis.